Okay, so sticker placement, and I think this is a big deal for you guys because a lot of you will be placing the stickers, so you need to understand the importance of putting them in the right spot. So, first of all, let's talk about limb leads. And really the three stickers you think about would be the right arm, so in this depiction they have it here, the left arm, and it is acceptable to put those where most of us put them up on the shoulder up here. And the reason is because anything that comes through from the heart this way has to go through that area, and so it's essentially the same as putting it on the wrist. Legs, I would recommend putting them in this spot down on the shin, and I think most of us do. You have to be cautious. If you put it up here, because you don't want to lift their pant leg up, you can actually throw off the axis of the heart, because if the depolarization is coming down towards the hip, and you put the sticker a little bit more medial, then you're changing that vector a little bit. Whereas if we all put it on the shin, then the next time the EKG is done, it's going to show the same kind of vector that it did the time before, unless if there's damage. And that's where it gets tricky. So if you move a sticker relative to somebody else, and we're not all on the same page, then when I go to read it, I have to figure out why did the axis shift? Did the patient have a heart attack in the meantime, or is it because we changed the sticker location? So it's important we're all on the same page. So limb leads. Sticker here, the next slide will kind of show the different vectors that those give. But basically, right arm, left leg, those make up the limb leads. So the connection between here is lead 1, connection from the right arm down to the leg is lead 2, connection from the left arm down to the leg is lead 3. What's the right leg? Anybody know? Ground, correct. So that's it for limb leads. So from that, you could get the limb leads. You can get AVR, where the positive is in the right shoulder. You can get AVL, the positive is in the left shoulder. You can get AVF, where the positive is in the foot, right? That's straight down. So now we have that half of the EKG taken care of, basically all of these here. And it's kind of hard to see, I'm sure. But 1, 2, 3, AVR, AVL, AVF. So how do we get V1 through V6? Now those are all the stickers that we put on the front of the chest, right? So V1, you're going to put it at the 4th intercostal space, just to the right of the sternum. V2, you're going to put it at the 4th intercostal space, just to the left of the sternum. And then 4 is going to go in the mid-clavicular line, 5th intercostal space. 3 you're going to put in between there. And then 5 you're going to wrap around to the anterior axillary line. 6 you're going to go to the mid-axillary line. Again, this is important that we all put them in the same spots. If you can see how the heart sits behind here. If you were to put it up in intercostal space or 2, you're going to change that entire vector, and it's going to change how, we'll see in a future slide, but it's going to change how the QRS looks in those leads. Everybody okay with where to put the leads? Any questions about lead placement? Good. I really just paused so that I didn't have to keep talking, honestly. Okay, so here's the limb leads. Again, I could talk for an hour about this slide, and I don't want to because you're going to just stare at me like I'm crazy. But overall, what this is looking at is the axis of the heart. So imagine that this is the right shoulder. This is RA is where you put this right sticker, right? LA up here, and then the foot down here, left leg, and this is the right leg's the ground. Okay? You get this triangle, and lead 1 goes from the right arm over to the left arm, positive there. Lead 2 this way, lead 3 this way. So if the overall depolarization of the heart, in most people, we said the heart is not sitting straight down like this, right? It's turned this way and it's turned up that way. And so the depolarization is generally going to go down towards their left hip. That's just a normal heart. And so this shaded blue area represents what is a normal axis. And if we were to damage part of the heart, let's say we damage the left side of the heart, we could shift that axis away from that area, because now those cells that were giving an impulse before are dead and they're not giving an impulse anymore. The other thing we could do, if we have a thick meaty heart, like with LVH, we could actually shift more impulse towards that thick muscle, and you can cause a shift in that way. So it's important to understand that the axis is meaningful, and putting stickers in the right place makes a big difference. I'm not going to get more into axis, but this is if you want to look at it later, that's a good slide to kind of work off of. I took a CT scan. This is a scout image of a CT scan. I'm trying to give you a better understanding of where you put the stickers relative to where the heart sits, right? And so this is that same diagram. Maybe this does better than the CT scan does. But the next one, you can see, is now the cross-section. And I hope this makes sense. In that this is your right atrium here. This is your right ventricle. Left atrium, left ventricle, right? And you have the arteries that correspond with those areas. But what you're looking at is V1 and V2 are your right-sided leads if you're talking about the heart in general. And so if you're looking for a right bundle branch block, it's important to look in V1 and V2. Lateral leads would be V5 and V6. And now you can see why this is. This is the lateral part of the heart, right? This is obviously the right side of the heart. Anterior leads, V3, V4, maybe V2, you guys have in your diagram there. And then the septum. So if we ignore the right side of the heart and we say, based on the left side, you know, what leads tell us what's going on with the left ventricle specifically. That's where we can look at these V leads and we can say, all right, the septum is closest to V1 and V2, right? V3, V4 are that anterior apical. And then V5 and V6 are more lateral leads. Okay, so that's just kind of how that works. Normally, the heart depolarizes this way, right, towards the left side, which is where you put the V6 sticker. So if that's the case, if you put the V6 positive sticker over here, it's like you're looking from this way, depolarization going towards that sticker, you'd expect a positive deflection, right? So it's normal for V6 to be a very positive deflection. The opposite is true of V1, right? And I hope that this makes sense. If I'm depolarizing the heart this way, and it's going towards V6, giving me a positive deflection, that means it's going away from V1. So V1 should be a largely negative deflection, right? And as you see it propagate around here, if my depolarization is this way, I should have a very negative QRS complex. Now I start to develop a little R wave, more R wave, and somewhere around this point, you've transitioned from having more of an S wave to now more of an R wave than an S, to the point where you have all R wave here, right? So this is the normal R wave progression as it goes from negative, slightly positive, more and more, until you get all the way positive on V6. That's normal. So damage to the heart can impact that, right? If you have an anterior MI, you lose the R waves up in this part of the heart here. Now V1 and V2 don't have R waves anymore. And so you just have negative, 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 and then you start to get R waves from the lateral wall. So that would be like an LAD lesion, right? LAD is right here. So if you knock out the LAD for whatever reason, you damage that part of the heart, you lose your R waves in that area. All right?